Welcome everyone. I'm John Maguire. I'm the Paul Glaucoma Implant Product Manager for Design Supervision, and I'd like to welcome you all here for the discussion of surgical aspects and new developments with the Paul Glaucoma Implant. I'd just like to quickly welcome our expert panel. We've got our Chairman, Professor Graham Lee, Professor Keith Barton. He's one of the principal investigators in the Paul clinical trials. We've also got Associate Professor Victor Coe, who's a principal investigator as well in the Paul clinical trials, and Associate Professor Andrew White, one of the early Australian pre-launch trialists and a very experienced Paul implanter. Also, I'd like to thank the contributions for our friends Marita Coe, Wilson Ing, and Layla from Advanced Ophthalmic Innovations, who brought the Paul to the market, and greatly appreciate that. So I'll let the meeting start and hand over to Graham Lee. Thank you very much.
Thanks a lot, John. So we're going to talk about surgical aspects and new developments with the Paul Glaucoma implant. And it's very focused. We're going to address the 3-year outcomes. Victor will address those. We'll look at tips and tricks for the particular tube, and we have some video footage, and we'll discuss it with the panel. And then we'll talk about tips and tricks for the actual plate. Again, some video and panel discussion. Keith's going to do a short presentation. He's just informed me that it takes longer than 5 minutes, but we'll give him a little bit longer as needed. And hopefully we'll have some questions at the end. You can certainly put some questions in the chat box as we go along, and that'll be able to hopefully address at the end, or as John said, we can do it afterwards. Okay, Victor, do you want to present the 3-year outcomes? That'd be great.
Yep. Thank you very much for this opportunity. I think we started a bit late, so I would like to maybe move on a bit faster. We all know about the Paul Glaucoma implant, and it is divided into 3 main parts. And I won't go too much into these details. We all know one of the most unique feature of this implant is the micro-sized tube with a smaller internal diameter. Next slide. When we first published the first-in-man study in a multi-center case series, this was all the way back in 2020, we managed to achieve pretty good outcomes. But this is a short-term 1-year outcomes, and I just want to remind the audience that these eyes also includes the learning curve of some of us who first used these implants. I remember that there were quite a number of eyes in which the tube were inserted into the anterior chamber without any stenting or ligation. All right, so I think that's the context, and the outcomes of this 1-year study is a reflection of the learning curve as well. But even then, the success rate is high, the failure rate is low, with a good safety profile. Next slide. And subsequently, there are other studies that also reflects the 1-year outcome. Next slide. Of the Paul Glaucoma implant as well. And if you look at the graph, next slide, you can see this very familiar reduction in pressure as early as post-op 1 month, and then remain quite stable. How do we interpret curves, pressure curves like this? It's not just the absolute or the mean intraocular pressure. It is also important, as what Keith has mentioned earlier on, the clustering. That means the spread of that pressure at each of the time point. You can see that that's the narrow standard deviation that is quite characteristic if you stent this implant with 6-O-Prolene the way we use, and this is quite reproducible in the subsequent papers by Luis Pinto and by Leon Au's group as well. Next slide. So this is by no means a head-to-head comparison. What I did was simply use the 1-year data from the first-in-man study and superimpose that to the RMAT and the Barvelt outcomes in the RMAT Barvelt comparison study. You can see that the PGI performs at least equivalent or around the same as Barvelt, and this is not surprising because the design of the PGI is a little bit more similar compared to the Barvelt compared to the RMAT. Next slide. The number of medications remain low. The medication burden reduced quite significantly in this first immense study. What I think was reminded of me recently is that the number of medications actually does affect the mean intraocular pressure at each of these time point. You could imagine that the number of medications at 1 month, 3 months, 6 months, and 12 months is low. But if you could increase the number of medication, meaning you put them on one medication, as we frequently do now to equal suppress them early, then the mean intraocular pressure can be lowered as well. So aside from looking at the mean intraocular pressure, it is important to interpret that mean intraocular pressure with the medication support that's required to hit that number. So that's one point that I'd like to highlight when we interpret pressure charts as well as medication charts. Next slide. And this is where the difference is. I presented this several times. The number of medications in the ABC study for both the ARM and above group is significantly higher compared to the PGI group. Next slide. The question, therefore, we would like to answer is whether the outcomes that we showed in the one-year paper is sustainable across a longer period of time. We recently published these 3-year outcomes of the Paul Glaucoma Implant, a case series that is focused mainly on eyes that have been performed in Singapore. Next. We use a definition failure of pressure of more than 18 or less than 6 millimeters mercury. One of the key difference between the first paper that we mentioned and this particular paper is the upper limit of the intraocular pressure cutoff. In the initial paper, where there is a more heterogeneous group, the upper limit for failure is 21 millimeters mercury. But we decided to lower it to 18 millimeters mercury because the severity of glaucoma in this group of patients are not as bad. So we thought that if we should lower the intraocular pressure, upper limit of the intraocular pressure for the definition of failure to better reflect the severity and the target intraocular pressure we want to reach. The other definitions of failure is consistent with what the World Glaucoma Association guidelines have set out to be, as well as complete success is defined as the absence of failure without the use of intraocular pressure medication. These are all quite standard definitions of both success and failure. Next slide. And this is what the outcome looks like, or rather, it is a retrospective single center case series. In total, we have about 48 eyes. The majority are still primary glaucoma, either open angle glaucoma or angle closure. There is a significant group of patients with secondary glaucoma like neovascular glaucoma, as well as angle recession. Next slide. This is the main baseline intraocular pressure. You can see that it's not so high, right? 20.6 mean intraocular pressure with supported by 3 eye drops on average, good visual acuity, and about slightly less than half of these eyes have previous intraocular surgeries, such as failed trabeculectomy or failed tubes before. Next. The outcomes are not surprising. You can see that the post-op year 2 and 3 pressure control remains quite stable after the first year, and this has to be interpreted together with the Kaplan-Meier curve, and I'll highlight something later on. Next slide. And that's the pre-op intraocular pressure, and the post-op mean post-op intraocular pressure is about 14 millimeters mercury at about 3 years time point. Next. If you look at the Kaplan-Meier curve, you can see that the majority of the failure happen in the first year, and subsequently many of these eyes remain quite stable with good intraocular pressure. The survival curve shows that the survival rate is about 85% with a complete success rate of 75%, and if you add that qualified success of 10%, you get about 85% success rate overall. Next. Once again, the medication burden remained quite low with a mean number of medications of about 0.16, which means that the majority of these patients do not require any medication support. So these patients are also in general quite happy. The ocular surface disease becomes less obvious for these patients. From the financial point of view, they are also quite happy because a single surgery like that means that they don't have to spend money to buy their eye drops to lower their intraocular pressure. Next slide. This is just a summary and a trend of the number of medication that is required before surgery compared to 1 year, 2 years, and 3 years post-op, you can see that a lot of them remain drop-free. And if you compare the number of medications in the other studies, you can see that the Leon's paper as well as Lewis's paper shows shows a reduction and significant reduction in pressure medication, but in general higher than what we presented in our paper in 1 year. Next. The 3-year outcomes can also be compared between the PGI as well as the RMAT or the Barbell using the ABC study. Once again, I'd like to emphasize this is not a head-to-head comparison. It is just a summary table comparing the outcomes in the PGI group versus the RMAT and Barbell group. So that's one limitations that I want to point out. We don't have good comparative studies at the moment that compares head-to-head outcomes. But you can see roughly speaking, the failure rate is relatively low compared to the RMAT and the Barbell. The pressure can be the same. You can see the mean intraocular pressure in the PGI is about 14.9 compared to the RMAT and the Barbell, quite similar. Mean intraocular pressure. The number of medications is also lower, and the complications rate you can see over here is comparable. Nothing shocking compared to the RMAT or the Barbell. Next. This is the reported complications from the paper itself. You can see in the left-hand column is what we reported in the first-year paper, and the right-hand column is the 3-year data. We superimposed that and compared that with the other European papers as well, and this is favorable compared to other papers that you can see reported in the literature. Next slide. I wouldn't touch too much on this aspects. You can see one key point is that in the first-year paper, which is to your left, there is quite a number of these patients with self-limiting shallow anterior chamber, and this goes back to my original point that I mentioned earlier on regarding the fact that we were still trying to fiddle with this particular implant, and in the first, I remember 20 or 30 cases in Singapore, we didn't quite stent the tube with Na6O-proline or ligate the tube. What we did was a mix of different maneuvers, such as leaving viscoelastic in the anterior chamber, using a pericardial patch over the plate, using spacers such as Hila flow under the conjunctiva to try to mimic or increase early post-op resistance to aqueous outflow. But even then, about 14% or 15% of these eyes have self-limiting shallow anterior chamber. None of these eyes had chronic hypotony that require second re-op or removal of the implant. Next. In short, the PGI is newish. I think we can agree that it has reached a bit of a maturity. The 3-year outcomes of the PGI seems to suggest that the implant is working well with a good safety profile. But like I said earlier on, we still need a better head-to-head comparative studies. With that, I thank you for your attention and I'm happy to take any questions.
That's great, Victor. It's great to see the 3-year outcomes, prolonged beyond that 1-year outcome. Can I just ask you, do you use mitomycin C?
So in all the eyes in the 3-year outcomes do not use mitomycin. Okay,
that's interesting. Yeah. How many do you remove the stent, the ones that you stented, do you think?
About 40%.
40%. Okay, that's interesting. So what were you going to say?
In the first-year paper, and that's the one where Keith is a senior author, there's a mixed bag. And there were eyes that were using mitomycin, there were eyes that had ligation, there were eyes that had stenting, there were eyes that had none of this. So it's a mixed bag.
Any other comments, Keith, Andrew?
No, my only comment was, when the PGI first came out, my original concerns were, will it be as effective as a barbell, or will we be, it's great having a smaller tube, but will we be compromising the long-term success in some way by having a different type, slightly different plate? And it's just encouraging that so far it just doesn't seem to be any worse than the Barvelt. And we've got the early pressures are more predictable, and the long term seems to be roughly the same as the Barvelt, maybe marginally better, but certainly not worse, which seems encouraging.
Yeah, I'd certainly agree with that. I think the pressure lowering effect is pretty much the same as a Barvelt, and you get some of the problems that you get with Barvelts as well. But it is somewhat reassuring that the lumen diameter is less. That gives you a bit of wiggle room on a few fronts, which is good. I hadn't thought about it till Victor had mentioned it, that when I put these things in, and I do with Barvelts too, I tend to have a very long bit of tudoplast. It is actually partially covering the tube as well. Hadn't really thought about what effect that might be having on flow limitation and encapsulation. And I haven't done enough, histological studies on enucleated eyes, thank goodness, to really know. The other point, we're talking about, you got the 3-year data here in Sydney anyway, where we've got registry data, the real world registry data that we're compiling with Mitch Lawler through Safe Site Registries, where we're all putting our cases in. And so we can do a lot of those comparative studies that you're suggesting would be very worthwhile to do.
Some people are concerned that the smaller lumen may not be as good for uveitic glaucoma. Do you guys have any comments on that?
I don't think it makes a difference.
You don't think it's a problem? Yeah.
Why would it be worse? Just more easily blocked or something like that?
Yeah, something like that. They think maybe 300 is better than 120, but you haven't found that.
No, I mean, the reason we went for the smaller tube with the PGI when, I was originally involved with Paul in the design was basically, the 300 micron means 600 external diameter, which is the entire drainage angle. So the idea, which is why you get corneal endothelial cell loss in the long term. The idea was to get a smaller tube. You're less likely to be damaging endothelium at the entry site, and hopefully less likely to get some erosion externally as well. Those were the only motives in making the tube smaller. The increased predictability seemed to be just a bonus that was unexpected.
Mm-hmm.
Keith, I've got a question since you're involved in all the design work. I was just madly during Victor's talk trying to find the bench data for the flow rate of a Paul tube versus a Barvelt, which is about 5.7.
Yeah, there are data. I mean, Victor's probably got it. I don't have it offhand, but originally Paul always said that the tube had some innate resistance, and I think it does have a small amount of innate resistance, but it's not much. The pretty much certainly the Barvelt and Amid, the actual tube diameters are completely way in excess of anything you need. They're producing no, you can evacuate an entire eyeball if the eye was aphakic and vitrectomized in a couple of seconds with a Barvelt. You can't do it quite so quickly with the Paul, but it's still got really no effective innate resistance. And I've certainly had one patient where I pulled out a stent and the AC just collapsed. It does happen. It's unlikely with a Paul, or less likely, but it does happen. So there's no, the unstented or unligated tube does not prevent hypotony by itself.
No, I was just curious. Just my guess is a Paul tube's flow rate something like 4 microliters a minute or something. Certainly enough to overcome standard aqueous production, but I'm just probably as a guess because I don't know. Probably a little bit less than a Barvelt.
Yeah. It's going to be.
So Andrew, you are right. We did flow studies, and there are limitations in flow studies. It doesn't represent what is happening in the eye. There are so many variations in terms of aqueous production, the length of the tube as well. So we were quite enthused initially when I saw the flow chart, and that's the reason why we didn't stent the tube when we first put into the AC. But what Keith said is true. The majority of them eventually require some form of of assistance or some of augmentation. I remember there were the times where we didn't stent or ligate. We put in viscoelastic. We choose a dispersive viscoelastic, for example, and for 1 week it's okay. The AC is deep, nice and fine, but almost always at 2 weeks when the viscoelastic has gone, the AC went shallow. And if the conjunctiva doesn't scar up enough to encapsulate and increase the resistance enough, you get shallow anterior chamber. So it's not adequate by itself. It's better, but not as good if you don't do something to limit flow.
I suppose that the flip side of that is, with the bar belts, when we stented them, you could get it wrong and get some really bad hypotony if you didn't get the stenting exactly right. Whereas with the PGI, with stenting, it's very few hypotonies if you stent it at all with anything. There is more, as Randy said, there's more wiggle room. You get, it's more forgiving.
So I'm going to present just a quick 2-minute video, and we can have a discussion with the panel after this. So this is using the ripcord technique, and it's a technique that I've really come to like. I take the edges off the pull tube, and maybe this is just one of my eccentricities, but I just don't like that sharp edge. So I usually put the 6-0-Proline down the tube while it's still dry. And you can see I have an instrument wipe just to give me some white background. And I find you can use the suture holders. It's quite good size for this. And often you get to a certain point where you can't advance the 6-0-Proline any further. I suspect it's due to friction between the amount of suture in the tube and the tube wall. You can give it a little pull and try to go a bit further, but yeah, you don't want to kink it, otherwise it just won't advance any further. So then I like to prime it, is a bit of BSS on a 30 gauge Rycroft cannula. This is actually skipping ahead to post-op, and this is a young fellow who had uveitis, and this is actually 18 months post-tube insertion, and this is removing the 6-0-Proline. So you can see I usually put the Proline into the inferior fornix. I have a fine 2 forceps here, and this is quite good at removing the suture. Now, you can imagine this has been in there for 18 months. He's a young fellow, history of uveitis. So, it does take a little bit of pulling because there's a bit of fibrosis around that Proline. But yeah, the thing about Proline is it's quite strong. It's stronger than the 3.0 Supramid. So it's actually okay to get out even at 18 months and probably longer than that. So that's removing that Proline.
Yeah, Graham, that looks like what seems to be a fairly common sort of technique for stenting. If you think you're eccentric, I'm more eccentric. Ever since the first ones came out, I actually don't stent them at all. I just use a really tight vicryl tie. And when the first box came with the first Singaporean fellow, pre-COVID, that's what we were doing, and I keep doing it now. I've had a succession of Singaporean fellows since, and we have ongoing arguments, and they've had various techniques, and most of them stent. Sometimes I still don't. A variation on the stenting technique is something that when people stent pressure flows as well, you see sometimes is they'll loop a long Proline through basically up as far as more or less the limbus near the cornea, so it can be pulled out like a releasable suture in a trabeculectomy. That's done for ease of access for some. I've seen some of my fellows teach me that one.
I suppose I tended away from the vicryl tie. It's just at the Bearville tubes I find that you get that initial 3 weeks of high pressures, and then you can release intraluminal Proline at that stage. But do you find you have those pressure spikes?
No, but I mean you're quite right that you got a smaller lumen diameter with the Paul tube, and so it crimps more easily. And so much like a lot of the teaching with the Barvelt, that wearing a little bit of high pressure with a bit of medical management till it pops is still quite useful. Saying that, maybe I've done enough of them that I just seem to get the tension right. I think that, I don't know if that's, good judgment or blind luck. I'm not really sure which. But a lot of the time it's not a problem. But some of them, with a tight vical tie, 4 weeks of a continued raised pressure that you've got to medically manage for a little while, that still happens. And the last one I put in, that is what happened. But I favoured doing a Paul tube, and I favoured a tie because the guy still had silicone oil in the eye that the retinal surgeons did not want to take out. And I did not want a large bore tube, which was just going to suck everything up from behind the IOL, which was sitting nicely. And so I was trying very hard not to poke a bear with a stick and still give him a reasonable pressure.
Yeah, that's another approach. How about you, Keith, Victor?
Well, I, as you probably know, I stopped doing the vicryl ties 25 years ago because with the Barvelts, they were just too binary. And we found that with increasing numbers of tubes, we're doing, patients with advanced glaucoma who have got starting pressures of, mid-teens on medications. And if you're tubing them and they're getting pressures in the 20s in the early postoperative period, then they lose vision. It's as simple as that. So, so I've been stenting the Barvelts since, about 2001, with various incarnations of the procedure, because although it wasn't perfect either, it certainly reduced that kind of binary effect that you get with the one tie situation. And the advantage of the pole with the stent is that we found that the early postoperative pressures were much more clustered than with the Barvelts. I did 4 PGIs on Wednesday last week, and day one pressures were 7, 7, 10, and 11. And they're not going to change much over the next few weeks, and they're not on any medication. Whereas I just find it impossible to do that with a ligating technique. So and obviously that's more predictable than we were getting with Barvelts, but even the Barvelts with a stenting technique, I just find much. The trouble is you need to do quite a lot of them to actually get a feel for what you can get away with, like everything. But I just find personally that I didn't like the ties simply because you didn't get those physiological pressures in the early postoperative period, and they end up on a lot of medications again, even, and still we're in the 20s. And I had patients say, when my pressures were 21, 22, I was actually getting worse. I've had patients tell me that.
And do you find that, you can remove the whole thing by 3 weeks or so, but what if you're getting pressures?
My default is 3 months minimum.
3 months.
We use a lot of mitomycin with the tubes, and if you're not using mito, it's like the vicryl. If you're not using mito, when the vicryl pops at 5 weeks, you don't get serious hypotony. But if you do use mitomycin, at least with Barvelts, when the vicryl popped, the pressure's really crashed. And again, I've had a few supermids with Barvelts over the years where if I pulled out the supermid or whatever in 5, 6, 7 weeks, you actually could get really bad hypotony. So I've tended to kind of keep them for 3 months, and mostly with the stenting technique you can get away with that. And if the pressure does go up, it's usually not a lot, and you can manage with something like Cosopt. And if it's really not manageable, you can adjust it. You can partially pull it. We tend to use the corneal loop that Andrew mentioned, and I think it was Chelvin Singh who browbeat me into using the corneal loop for poles, and it actually does work pretty well because then you can pull it out in the cornea easily. But if you have to adjust it, then you lose the corneal loop. But it's not unreasonable in the early postoperative period if you get a high pressure to partially pull it.
Yeah.
The only downside is you lose the corneal loop and you've got to pull it out from under the conjunctiva next time.
Yeah. Thanks, Hugo. Any other comments there, Victor? Do you do anything different?
You know, Graham, what Keith says is true. I think we are talking about reproducibility and predictability especially in the early post-operative period. For a novice surgeon, I think putting in a stent makes you sleep better at night. That's number one. Number two, not all the stents needs to be removed. If you use the Vicro, then you almost always will get it resolved by maybe 4 weeks or 6 weeks, and then that opens up, and some of them may crash in terms of pressure. Whereas with the stent, you could potentially leave it there, right? And not having to remove that as well. I am quite interested in finding out, is that your routine technique of burying the proline in the inferior fornix?
Yeah, well, I actually put the proline in before I put the tube in, but once I've got the tube, the plate under the muscles, I'll use the proline. I used to leave the needle on the end, so I can actually tunnel it into that inferior fornix pretty easily with the needle on the end. I haven't tried the corneal loop, but I'd be interested in giving it a go.
So I routinely do the corneal loop. It's easier to retrieve. I sometimes find that if you bury under the conch, the encapsulation or the bleeding makes it a bit harder to retrieve.
Yeah, I try not to bury it too far into the fornix. You can get caught sometimes with that. Yeah.
Graham, can I ask one thing? So when Victor's getting it, how do you manage to flush it whenever the proline's already in it? That intrigued me.
You mean flush the tube? I actually haven't had to flush a Paul tube. I've certainly flushed Bearveld tubes, but haven't had to flush.
Do you not flush them routinely to remove static and ensure that get all the air bubbles out and stuff?
Well, I put the proline down and then I prime it.
Yeah, that's what I mean. How do you manage to prime it with the proline in? They're quite difficult.
Down, and I make sure it goes down so there's no bubbles. Yeah.
Would it act a bit like a wick when you're priming?
Like a wick.
Yeah. So with a high sort of meniscal tension, it's going to crawl along the proline like a wick. I don't know. I've just spitballing.
No, I've got the proline down. I put a 30 gauge Rycroft and give it a good squeeze, and I can see the BSS coming out the end, so I know it's fully primed. Well, that's great discussion. We'll probably move on. This is a technique I picked up when I was in Manila recently at the APGC, and Keith and Victor and Andrew were there as well. So this is a case of tight orbit syndrome, looking at putting the tube in intratemporally. So I've got the plate in there, and I've got the 6.0 proline, and there was a stretch of the tube to get this proline out. And that's a trick that Keith mentioned in his talk in Manila. So it can be a struggle sometimes getting this tube into the sulcus, and that is my preferred placement if they're pseudophakic. So this is using a guide wire technique. This is actually Mary Q from Chicago presented on this, so I can't take credit for this, but this is a modification. So this 25 gauge needle passed through under the iris into the sulcus, into the sclera, and you can see I fed the 6.0 proline into the 25 gauge needle, and you can't obviously pull it into the eye with the 25 gauge, but because the proline is in the right position, you can just use it as a guide wire to just gently ease that tube into the sulcus. So you've got that proline hanging out there, so you cut it short, And as I said before, I have the Proline on a needle in the inferior fornix, so I can just pull it back just to the end of the tube, and that gives you a tube in the sulcus. And the other cool thing is you can adjust the length of this tube in the eye by doing a curve type entry, and that's something that Mitch Lawler in Sydney presented on a few years ago, and that's a nice technique to be able to adjust the amount of tube in the eye itself. So, any comments about that?
Yeah, I'm not used to guide wire technique. I mean, it's a good idea for sure. I know Mary's been promoting it, and it's perfectly reasonable idea. At times, I think I probably should.
I find putting the pull tube into the anterior chamber is not too hard. You know, it seems to be easier than the bell. I'm not sure why, but
that's kind of why I've never gone to using the guide wires, because I kind of always manage some way or another. But occasionally I get a difficult one thing. Well, maybe I should do the guide wire thing.
Are you putting them in the sulcus, Keith, for pseudofakes, or
No, the AC largely. I mean, if there's PAS or narrow angle, I'll put them in the sulcus, or I'll put them. One of my favorite techniques is to stick it in through the sulcus, but leave the tip in the AC through through an iridotomy or a hole in the iris.
Right.
I mean, I've used pre-existing iridectomies. You could even get the PGI through a laser iridotomy hole, or just use a needle to go through the iris. But I don't like blind sulcus fixation where you can't see the tip, because one of the problems with blind sulcus fixation is it can end up in the vitreous or somewhere else, which admittedly is not going to happen with a guide wire technique, because at least you're guiding it, and but they can end up all over the place if you can't see the tip. That's my only concern.
That's why I think I like the guide wire technique.
Yeah.
It put in where it should be. Do you believe that putting it in the sulcus is an advantage in terms of reducing endothelial damage?
I think our prospective study of endothelial cell count with Barvelt showed that if you had them flat on the iris at the entry site and away, and in other words, if the entire tube was behind Schwalbe's line, then the endothelial cell loss rate was very similar to sulcus fixation, to published sulcus fixation rates. I mean, Ying Han at UCSF did this anterior chamber versus sulcus amide study and showed that the sulcus was better, which is not surprising. But our study in ophthalmology glaucoma in 2020, we showed that it depends where the entry site is in the AC, and if the entry site's close to iris and behind Schwalbe's line, then our endothelial cell loss rate was actually slightly better than her sulcus endothelial cell loss rate, but it certainly was no worse. And the PGI being like 2/3 the diameter of Barvelt, at least if you put it in the AC, behind, it's easier to get it behind Schwalbe's line because because it's a smaller tube.
Less volume, yeah.
And sulcus tends to bleed more, which is kind of a pain. But
I was just wondering, and it's just an observation. I don't know whether there's any studies on this, but the entry, if you were to do it, if you were to insert the tube through the sulcus versus inserting it through the anterior chamber, do you think that the angulation of the tube entry is a little bit maybe less acute, and that might reduce the risk of conjunctival erosion?
Oh, conjunctival erosion, yeah.
Is the bend in the tube less? I don't know. I don't see why it would be. I mean, I tend to angle the tubes tangentially and into the AC at the close to 12 or 6 o'clock as possible, with no kind of bend in it, because any kind of bend promotes, or any kind of angulation promotes erosion. But I don't know if sulcus is any less. The other thing I would say about sulcus is it's a shorter external course. So therefore, you'd think it would erode less, which is perfectly reasonable. Yeah, I mean, if I get a multiple erosion, I'll put it in the sulcus.
Or it's just by being further away from the limbus, you know, more
Yeah,
coverage.
no, that's perfectly reasonable. Yeah, your shorter external course is going to be better. I just like to see the tip. That's all.
Yeah, definitely. I like to cut the tip of the tube bevel down if I'm going in the sulcus.
Yeah,
that may help some of that problem of blockage. Andrew, do you have any other comments?
Yeah, look, I echo the way Keith puts it in. I'm not sure it makes a difference, but the sulcus is a shorter course. In terms of the bevel, because I saw in the comments, I think Jesse was asking about that too. I don't know, for some reason, the way I was taught, if you're doing it in the sulcus, I just actually put it in square rather than beveled at all. It's a bit more fiddly to put in, but yeah, it still goes in fairly well, and there's a variety of techniques. You know, your Proline one that you've showed, yeah, that's a really neat idea, and there's some slightly more overcomplicated handshake techniques, because yeah, I also agree with what Keith said. If you're not having some sort of visualization and guidance, that in a sulcus placement the tip can end up anywhere.
Yeah, that's why I went to the guide wire. Yeah. Victor, did you want to present your intrascleral tube insertion? Yeah.
Yep. I think in Singapore where I practice, we don't have sclera or cornea that is easily available, and so the most common patch that we have is the pericardial patch, which I think you and I know tends to melt, tends not to last for too long. We have the fascia lata. The fascia lata is a little bit a lot more expensive. I always thought it's a bit more bulky and thicker as well. So sometimes I do get Dallin formation as well. So I thought maybe another way is to sort of reduce the micro movement of this tube and try to get it intrasclerally for a longer part of the course of the tube. Can you play the video? So what I do is that I measure about 3.5 to 5 mm tunneling using a 25 gauge needle, and you know I create that sclera cuts to allow me to gauge the depth better. That's the 25 gauge needle. Pardon the resolution is not as good, and that is the 25 gauge needle going through the first tunnel. You try to look. You try not to perforate the sclera, and the trick over here is to just manage to see the metallic shine of that needle, and that's the second pass. You shorten the tube as per normal. For some reason, the video has frozen. Can you play that? You shorten that you shorten that as per normal, and you go through the entire length of the tube. You can see that the tube is starting to go in. And for about half of that length of that tube is covered by sclera now. On top of that, I still use a pericardial patch over this tube. And I thought that might reduce the risk of exposure. Next slide. I'm just putting this up for discussion. Next slide. Yep. So it's a two-stage thing. I try not to do it in one stage from all the way about 4 or 5 mm from the limbus, because I find it very difficult to position the needle into the anterior chamber parallel to the iris plane. So I do this in 2 parts, and I thought that this way we could reduce micro movement of the tube, and there's extra cover over the tube. Next. There's a learning curve to this, because when I first started doing this, it is not as easy. Sometimes the two tunnel doesn't connect to each other, and the second entry into the anterior chamber, sometimes you don't quite get it right, and you have the tube pointing anteriorly. So there is some learning curve to this, which I have kind of overcome, and this is something which I've been doing quite routinely. So far, fingers crossed, I hope that such a technique allows me to reduce the risk of conjunctival exposure. That's all I have.
Yeah, nice technique, Victor. Like I was in Cambodia recently, and they don't have sclera over there, so we used a similar technique, except we were using scleral pockets. So we're using a crescent blade to make the pocket, and it took 3 cuts actually, and it covered a bit more of the tube, but a very similar principle to your needle. So yeah, very useful. But you said you still use pericardium over the top, or?
That's right. It's a bit of a, yep. I still use that as extra cover.
Yeah. No, nice technique. Keith, what are they using at Moorfields these days? Is it sclera or Tudoplast?
I use fascia lata. Because I find pericardium just disappears. So the history with this is we used to use donor sclera cornea in everybody, but we kind of the eye bank were decompensating. So about 2009, it was, I think, Peng got Tudoplast in pericardium, because, and we used that for a while. But after a while, we realized the erosion rate was higher. Pericardium does tend to disappear, so a lot of people double layer it to prevent that. And I was in Doha one day, and I saw a couple of tubes that had been done in Spain, and realized it didn't look like pericardium. So asking around, found they were using Tudoplast fascia lata, which is definitely thicker. Comes on a shelf like the pericardium, so you don't have to order it and fill in 100 forms for the eye bank. Ideally, I think my colleague Gus Gazard uses cornea in everybody, but I think if I did that, I would use up the entire world supply of cornea pretty quickly. So, I tend to use cornea for the inferior tubes because it's a bit more unsightly, and fascia lata for the superior ones. But if you're, things like donor sclera is still more robust than anything else, and cornea is probably better cosmetically than anything else. But fascia lata is a reasonable compromise.
I suppose we're still using sclera in Brisbane. About 10 years ago, we got very keen on tubes, and they ran out of sclera, and then they started putting it into 4. So we've quadrupled the scleral supply, and we've been okay since then.
Well, I mean, we've got like 24, 25 glaucoma specialists at Moorfields. I've lost track, and I did like 6 or 7 last week. I had 4 on Wednesday. I had a few revisions. I had a couple of 3, I think, on Thursday, 4. So we did 7 last week. So it'd be difficult. It's difficult.
Yeah, no, that's true. And sclera can be variable thickness too. Sometimes you get thin ones, sometimes you get thick ones.
Yeah, I mean, you got to use something. I mean, I do like the burying it technique is elegant. If you don't have anything, it's elegant anyway. It's a question of making sure the tube's completely immobile, so it's not moving, because that probably causes erosions, and that there are no bends in it. And if you can manage to achieve kind of straight tube with no bends and no movement, you've got a decent chance of not getting an erosion, I think. And a lot of that after that depends on the patient, how thick their tenones are and things like that.
And what do you use in Sydney down there?
Yeah, so I mean, where we do it at Westmead, which is about 20, for those that don't know geography of Sydney, it's about 20 kilometres west of the CBD. We have it's rather difficult to get sclera in a hurry, so we use double layer Tudoplast, which gets us through most of the time. I do think in this day and age doing a single layer is nowhere near good enough. For those that are repeat offenders, usually we do try and obtain some sclera for an erosion. A lot of the time, one of the issues with when the tube erodes is the conjunctiva is in worse condition than the patch graft that you're using. And so one of the things that I find quite useful, and it has a little bit of tensile strength in itself, is doing a buccal mucosal graft over your sclera. That tends to be one of the most robust and accessible things for us. We just like having Tutoplast on the shelf because we're probably the major trauma centre for ocular trauma in Sydney. We get most of it, and so a lot of the time we need something to cover an unexpected hole in a hurry.
Does buccal mucosa not take a bit of effort and time to harvest?
Not really.
I mean,
no.
Yeah, I mean, John Dart used to do it, but it always seemed to be a bit of a deal. That was all.
We've never
tough-
found
it's
it a
tough
huge
stuff, though.
deal. Yeah.
Yeah.
You do it
Yeah.
yourself, Andrew? Yeah.
Sorry?
You do it yourself? You just take
Yeah,
a bit
just
from the...
do it
olive?
ourselves. You know, it's normally fine, not a big deal.
Yeah.
Okay.
Yeah, no, it'd be a good technique to show us one day.
Yeah, sure. I didn't get my videos ready in order. For next time, sorry.
That's okay. Okay, well, we'll move on. We'll talk about plate placement next. I've got a video of a patient, the same patient as I showed guide wire, but she's got tight orbit syndrome, and she's really got no space under the superior lid. So this is me sitting temporally doing infratemporal placement of the plate. You can see a conjunctiva is just so thin that you can just slice through it with the scissors. I like to hydrate this kind of tenons, just to give it a little bit of thickness, because the last thing you really need, is to buttonhole this sort of conjunctiva, and it's very friable too, so you're very prone to tearing. I tell my juniors when they're putting plates in to make sure they get good exposure of the muscles, and to make sure that all the attachments and tenons and check ligaments have been cleared. So this is just placing the Paul tube. And the plate is more flexible than you would with a bare belt, but it's not quite as long as a bare belt. So sometimes I find that the wings don't always sit under the muscles well, but apparently it doesn't matter if they do sit above the muscle, although I do prefer it to be behind the muscle. I usually like this plate to be at least 10 millimeters back, and I think this is important because the ones that I have had problems with erosion are ones that have migrated forward. So I do like to place those, at least the suture placement for the holes 10 millimeters back.
I think for people that aren't used to it, if you're used to putting bar velts in, you do rely on the innate sort of stiffness of the bar velt tube to sort of swing things under the muscles. You can't really do that with a PGI very well. You do need to use things like squint hooks and things like that, because relying on the rigidity of the PGI itself, it's not going to sit under any muscle.
I spend
Yeah, so
significant
even
amount.
poppier than the bar belt. Yeah.
I spend quite a significant amount of time dissecting, the conjunctiva and the tenons, and then making sure that the space between the muscles and the sclera is there, for the plate. Like you said, it's not as rigid as the bar belt, so you can't quite squeeze it in. You can't quite, you have to maneuver it, and you almost have to place it in, and not shove it in.
Yeah, I don't know if it's a blessing or a curse, but sometimes you can do things with a bar belt with brute force. You can't really do that with a PGI.
There's no blunt dissection with a PGI, is there? No. Any tips on infratemporal placement?
No,
Okay, is that your preferred second position, or do you have any other comments?
Who, me, Andrew? Who? Sorry.
Well, Keith, what do you reckon? Look,
I tend to go in for nasally second, because usually there's a something big plate supratemporally, and it's harder to put plates in adjacent quadrants because they bump against each other. I mean, that was especially true of bar belts. It's less true of PGIs because the diameter is not as much. But infratemporal is a slightly more attractive quadrant than infranasal just because there's more space. But other than that, simply because it's getting one plate away from the other, I tend to go 180 degrees away. And they're pretty much always second tubes. If I'm going inferior, it's pretty much always a second tube.
I suppose I did infratemporal that lady because it was so tight. And
yeah. Infranasal can be a bit, there's less space. So if it's tight, infratemporal is better.
That raises, I guess, an interesting point with tight orbit syndrome, which we all encounter. I mean, how much do the rest of the panel, do like a canthotomy, cantholysis, and give yourself a bit of room to put something in?
I don't, because I tend to get it in. I mean, with tight ones, I find there's usually some way you can get it in. It's closing afterwards. It's more of a worry, and whether they're more likely to get diplopia because you've got this kind of brick on the outside of the eye and the eye's moving. So I worry more about the after effects than the actual implantation, I suppose.
I had to do it once, and it makes the work a lot easier. Suddenly feel a lot more space.
Absolutely. I mean, the reason it springs to mind is this morning I had one of my registrars putting his first hydrus in for a woman who had such a tight orbit, couldn't even get to the cataract, and it was just like, okay, give yourself some room.
Yeah, it's a good tip if you're really struggling, especially with the smaller Asian eyes. I'm surprised you haven't had to do it more often, Victor, but it can be an issue.
Graham, having said that, when I put in the second tube, this is my personal preference, of course. I would hear from you as well. I tend to put it in the superior. If the superior temporal side is taken and the superior nasal is available, I still like that side quite a fair bit. Mainly because coverage or by the upper eyelid is a bit better at the top. I understand that maybe there's less space because the superior temporal part is taken by a tube. What do you think about that?
Actually, it's great to see so many quadrants being used here. Obviously, there is a variety of techniques.
It used to be it used to be kind of like preached that you didn't use supranasal for bar belts because the risk of superior oblique syndrome, and as a consequence of me trying to preach that at Moorfields, pretty much everybody did supranasal just to spite me, I think. And they didn't seem to get. Ian Murdoch used to always say, well, all of his patients only had one eye, so he never got double vision. But a lot of people did do supranasal. I haven't, because there's less space, and because I was brought up not to do supranasal for bar belts because of the risk of severe oblique entrapment. So I've tended not to do them. But Maria Papadopoulos always did them and never seemed to have any worries.
Maybe a 350 would be a bit big for supranasal, but 250 is all right, isn't it? 250 fits all right up there. Yeah.
It's a small and vaguely cosmetic point, and if you're up to your second tube, I don't know how big a factor it is, but look, part of what Keith said is my teaching was always avoid that quadrant, but two, a superior nasal bleb of any flavour is going to give you a rotten tear film, which makes people miserable.
Yeah. I don't like superior nasal blebs of any sort, but I must say that wasn't my main motivation for not doing supranasal bar belts, but it's certainly, consideration.
Interesting. Okay, Keith, did you want to do your presentation on plate erosions? That would be good.
Yeah, I mean, I put some stuff together, but this is. Let me just get sharing.
We could probably give you 10 minutes. Will that help?
Yeah, let me run through it because I came up with a few scenarios.
Okay.
Nobody ever asked me to talk about plate erosion before, and it's not a common thing, thankfully. Okay, so this was a 42-year-old Asian male, had Leber's amaurosis, had very high IOP after gene therapy that was missed, and had a PGI done by one of our very experienced fellows. And a couple of weeks later, it looked like this. This guy this Asian male came back a couple of weeks after. Now, a plate erosion like that after 2 weeks is a bit unexpected and dramatic. And then you've got a couple of things to consider, like, is it infected? Obviously, did he put it in like that in the first place? So the answer is no. This was an experienced surgeon. You can see from the length of the tube that the whole thing's migrated. And what do you do about it? So I took him back to theatre, and because it was only a couple of weeks after the initial implantation, I think it was maybe 3-4 weeks, it wasn't encapsulated at all. Obviously, it had to come out, but the issues with plate erosions is one is you're often a lot of scarring in a pool of blood, which this wasn't because it was early, but you've got a mucky plate that needs to go otherwise because there's a risk of infection. And the question then is, do you replace it with something in the same quadrant or another quadrant, or you just pull it out and don't do anything? And end up, I replaced this with another one on the same quadrant for a couple of reasons. One is that he wasn't, the plate was mucky. There was really no sign of infection. He was vehemently opposed to having more than one operation, in other words, closing it and doing another one later. And I was somewhat reluctant to use a separate quadrant, screwing up 2 quadrants. So I put it in a little bit sort of back to front, simply because I wanted to get the tube into the AC to close that site. I was trying to use the same AC entry site before stitching the plate on, which is obviously not the way I would normally do it. And that was fine. And closed it all down, and post-op it migrated again, this time the other direction. So the first time he had migrated forward, exposed the tube. The second time he just migrated backwards, which was completely different. So in fact, this guy seems to move tubes all over the place. I didn't want to move it again, knowing that that his eyeball is going to move it again. So I ended up extending it with a piece of Barvelt, which Ali Martins had done and somebody else a couple of weeks beforehand. We know what prior to this, we'd never extended a PGI before, but the fellows told me, Ali Martins extended one with a bit of Barvelt, so I did the same. Then I tested it with Vision Blue just to make sure it wasn't completely compressing the tube and squeezing it. Closed it up, and that's the bit of Barvelt on the end of the PGI. A bit of glue, replaced the previous patch, closed everything, and first post-operative day looked okay. 6 months later, looks okay. So this kind of just the bit about adding the Barvelt was an optional extra. The thing is, plates exposure, in my experience, they either migrated, or they were too close to the limbus in the first place, or it was so scarred you couldn't cover it in the first place. But most of them, I mean, they rarely happen. When they do, it's normally migration, in my experience. And when revising them, areas of tubes are always surrounded by an area of very stuck down conjunctiva, and exposed plates are even worse. Is the plate mucky? Could it be a reservoir for infection? Do you put another plate in the same place if you're taking it out? What do you do? My options are chop off a bit of the plate, stuff a large piece of donor tissue through the hole, mobilize, conj, close up and pray, reposition the plate or replace the implant. I mean, there's no chance of just salvaging that existing one that I just showed, or give up and remove the implant, which I'm reluctant to do. this was an 87-year-old white male with bilateral advanced POAG who came to us NPL in one eye from primary open-angle glaucoma, despite prior trabs. And I put a PGI in the other eye, and it exposed after 4 months, like this. So anyway, extensive mobilization and pull of blood, but you can see what I meant about, you know, the conj. It's always super tight, and there's really no chance of getting it mobilized enough. But anyway, mobilize. Chopped. The plate wasn't really that far out of position. It was only it only moved marginally. So I thought it'd be easier to cover this if I chop a bit off it. And people have, you know, described this with amputating bits of bar belts in the past, but I think this is the first time I've done it with a PGI. So, and then mobilize a bit more. Chop a bit more off. Try and stick a bit of pericardium through the hole. This, I usually try and get the biggest piece in I can. This was too big, so this was not going to happen. So then I took it back out again and cut a large piece off. Again, stuffed it through the hole. And there still wasn't any chance of closing the conj here, even though it's a relatively small hole. It's just very tight. So I took a conjunctival autograph from inferiorly, which you'll see in a sec. So that's pericardium to try and protect the conj from the plate, which now has some sharp edges. A bit of conj autograft, which then glue over it just to hold it in place while I stitch it down, and then and you can see that unlike a pterygium conj autograft, with these you just take the tenons and everything, so you've got as thick a sponge as possible, and then sutured down, and that worked pretty well, except that 15 months later it exposed again. This time I repaired it putting fascia lata through the defect and managed to close the conj. I don't know how. I don't have the video for that. But anyway, this guy had a desec 5 months later, no further exposures, 13 months after the second repair, thank God. But he's now 90 years old. He's got 8mm mercury pressure off meds, 636 in his only eye, and he's the carer for his wife. So we've managed to keep this guy caring for his wife some way or other by and without giving up on the tube, and managed to keep his glaucoma under control. It's all a bit of a miracle. So it's kind of a qualified success, shall we say. Stuffing the thing through the hole. This 76-year-old female had had a detachment post-vitrectomy glaucoma, plate exposure 9 months after PGI, and again it was really tight. The plate position wasn't bad, so I didn't move it. I used one of my favorite techniques here, which is to put in a whole lot of traction sutures to pull the tenons back, proptose the globe a bit, and give you a bit more visualization. And then again, try and mobilize the conj in a pool of blood as usual, and try and get a lip. The reason for trying to get a lip all the way around was so that I could stick some fascia, actually I think it was donor sclera through the hole. And you can see the stent still in situ there. That's donor sclera. Again, trying to get the biggest piece as possible. That was too big, so I had to trim it down a bit. Stick it in again, and eventually that goes in. And then because I've made a little rim, I can tuck it in all the way around. I use glue to partially hold it in place. I mean, you can't rely on glue for this, especially the frozen stuff. You need to suture as well, but it gives you some kind of anchorage. And then close it all up, and I pull the proline out at the end.
It's not fun surgery, is it?
Yeah. I mean, I never get the opportunity to show these rather photogenic videos. And
Yeah, really.
much as I hate atovicral, because it's so inflammatory, it's pretty good in these, you know, where you actually need a hawser to close the conj. And this 10 months later, no further exposure. visual acuity's kind of where it was. Pressure's not brilliant, but not too bad. So it can get you out of a hole. Obviously, I've talked about repositioning the plate, which is good if it's an early exposure and everything's mobile, but it'd be a nightmare and late. I've had later plate exposures years ago where the plate had migrated, I repositioned it, and then I just migrated again. And the problem with migrating plates is if you reposition them, there's a chance it's going to happen again. Or you give up and remove the implants. And, you know, the only thing about removing implants for those who are unfamiliar with this territory is that you've got to cut all the pegs at the back, otherwise you can't get the thing out.
That's true.
You know, if it's been there, those ones, the one I showed earlier wasn't really anchored down because it hadn't been there very long, and you know, but you can't really see it there. But you've got to get these. There's a good example of fibrous pegs, and you can be pulling and wonder why it won't come out, and then try and chop up the implant. But in fact, all you need to do really is get at those pegs, and that's pretty much it. You know, I was going to say thanks for the opportunity to talk about plate exposure. I don't think anybody's ever asked me that before.
Yeah,
and unfortunately, I don't think any of us see very many of them. Hopefully.
Yeah, it's such a nightmare. I think people have presented on before putting autoconch graph over the top of the plate, and it just doesn't work. It just re-exposes it.
Yeah. You've got to.
Yeah.
I mean, where do you start, really?
Do you think sclera is probably the best material?
Yeah.
Yeah. Okay.
I was a bit disappointed with that one that I stuck pericardium in, and it eroded again a year later. And I just wonder if I'd stuck donor sclera or something like that through, maybe that would have been enough. But I mean, that plate was sticking out, so it either had to be moved or amputated, and just moving a plate that's really embedded is like a difficult one. So amputating it seemed to be the most logical thing.
Yeah, no, it's good to see that it can work. Any comments?
Yeah, I think the only message is that, you know, it can be done sometimes. Don't just give up on it. But there, you know, it has to be some kind of rational approach, I guess.
Right, there's no infection, I think. Yeah. Andrew, Victor, any other comments?
Yep. Do you think that mitomycin has a role to play?
I used to wonder that. I don't think so. I mean, we put the mito quite far back, you know, over the equator. I mean, okay, you say, well, it sloshes around a bit at the front as well, but I tend to dry it off very quickly when it does. So I can't see that it has a major effect. I certainly plate erosion's rare, you know, and you could say, well, it is the area of the plate, but still plate erosion's rare. Maybe if we didn't use mito, we wouldn't have any plate erosions. I don't know, but it's still very few cases, I see.
I had one, and you know, we tried to repair it using part of the upper eyelid tarsus, part of the upper eyelid mucosa, you know, and the conjunctiva as well. You create a flap near where the erosion is, and you try to use that to patch. It seems to work out initially, but after 6 months, it erodes again. And then this time around, I had no choice but to remove the entire plate.
Yeah, I guess it's what the plate's doing. You know, if the plate's sticking out, and you know, you may need, you know, you got to stop it from sticking out somewhere or other, either move it or chop it or something, because it can be hard to stop it eroding again. And then you have something really robust over it. I was interested in the buccal mucosa because I think it's pretty tough stuff.
Very tough stuff. Yeah.
Yeah, I mean, I saw John Dart doing it years ago, and the only reluctance with using it is the hassle in harvesting it, I guess.
Yeah, you can just take it from the inner aspect of the lip, just with a bit of local
Really?
infiltrate. Yeah.
I think John used to be taking it from the hard palate.
Oh, no, you don't need to do anything that fancy.
Oh, really? Okay, no, that's what put me off. I'm pretty sure that John Dart used to get it off the hard pallet.
No, just
I might be
the
wrong.
inner
I mean,
aspect of
it's
the lip
decades
is
since
fine.
something.
Yeah, that
Wow.
works quite well. I have to say, you know, I'm something of a defeatist when I get plate erosions and things like that. And in general, because of the fibrous pegs, the plate has started moving early, so it's never really got the pegs properly. And then, yeah, pushing it around, it's generally stuck where it's stuck. And so covering it, amputating stuff, my sort of approach usually is that I'll just take the whole thing out, let everything recover and come back and manage it some other way. And that seems to be the most effective way in my hands anyway.
Well, that first guy, I was inclined to just take it out and close up and then put in another one somewhere later if need be. But he was, he'd been through the mill, and while it's important to do the right thing and not just do what the patients want, if it's the wrong thing, it wasn't quite mucky, and the area, there was no sign of infection. The plate was a bit mucky, but the area was clean. So I thought, well, okay, I'll give it a go, so that try and fix them in one go. But of course, he then needed another revision because the plate moved the other way. But he did eventually settle. I mean, he has now got a tube in the eye and the pressure's okay, so maybe it was worth the effort. His big problem was that he had gene therapy and nobody measured the pressure afterwards, and he, by the time we saw him, he was already screwed, unfortunately.
That was fantastic, Keith. Horrifying stuff, but great to see the options. I'm aware of time. It's 8 o'clock. Are there any burning questions, John, out there, or should we leave the questions till some other time?
Yeah, Graham, because of a matter of time, there are some questions. I'll put them all together because we're recording all the questions and the event, and we'll put them back to you guys as a panel to answer. I've seen that Keith has answered a few already. And we'll edit this video and have it put out to the viewers and yourselves to review. Is that okay, Graham?
Yeah, that'd be great, John. And
yep.
Thank you so much, everybody, for attending. It's been great having Keith, Victor, and Andrew for our expert panel. And again, thank you for AOI and Designs for Vision Paragon for hosting. And thank you everybody for attending, and I hope you learned something. I certainly did. So good night, everybody.
Thank you. That was really excellent. Thank you very much. Really great.
Bye.
Bye.
Thanks, guys. See ya.